Hello, everyone. This is Dr. Farouk. Today, we're going to discuss some sample question for FRCEM primary exam or MRCEM SBA. I've tried to bring some question banks, sample question papers from the RCEM website. Let me share my screen. Right. So here is a simple question for FRCEM primary, which was going to be changed to MRCEM SBA this year. Question number 1. All right. You examine a patient in emergency department and find that there is visual loss on the left side of the vertical midline in both eyes. Occlusion of what type of blood vessel is most likely to be the cause of these clinical findings? This is looks like very simple question, which is not a very straightforward question, because first of all, they're asking us what type of lesion we are describing here is homonymous hemianopia, left-sided homonymous hemianopia. And then we need to know what anatomical structure we're looking at and the blood supply. All right, so let's look at some imaging. Right, so this is the diagram for the visual pathway. So we can say starting from the eyeball, optic nerve, and optic chiasm, optic tract, down to lateral geniculate body. Then these are the Meyer's loops, optic radiation, and visual cortex. Okay. And on the right side, you see the diagram of the type of the lesion. So homonymous hemianopia, that these homonymous hemianopic lesions starts beyond the optic chiasm. So the lesion must be after the optic chiasm, right? And it could be either optic tract or optic radiation or even the occipital cortex. However, if you look into the lesion in the occipital cortex, it says it is homonymous hemianopia, but with macular sparing. The question does not describe any evidence or anything about the macular sparing. So let's not assume the lesion is the occipital cortex. Let's say the lesion can be either the optic tract, which can cause homonymous hemianopia, or these over here, this is the optic radiation. So where is it? The other thing is, yes, there are loops. So the superior and inferior Meyer's loops. So these are both causing, one second. So both these are causing quadrantenopia. So it's not actually hemianopia. The superior Meyer's loop cause, which goes through the parietal lobe, cause the inferior quadrantenopia, and the inferior Meyer's loop, which going through the temporal lobe, cause superior quadrantenopia, which is obviously contralateral. So in terms of homonymous hemianopia without macular sparing, the optic tract is one place and the optic radiation. So what are the blood supplies for optic tract and the optic radiation? Let's find out. Well, this is the very good diagram from deranged physiology. It's showing the blood supply of the visual pathway, right? So this is the optic tract, is supplied by posterior communicating and anterior caudal arteries, right? That's good. And here the Meyer's loop is actually supplied by the middle cerebral and anterior and posterior cerebral artery. Sorry, middle cerebral and the posterior cerebral artery. This is the Meyer's loop. And this last bit, both the optic radiation and the visual cortex, both are supplied the posterior cerebral artery. So if you were looking in this area and the optic tract, we will be looking at blood supply, and the answer stem is either posterior cerebral artery or posterior communicating and anterocoroidal arteries. All right, let's go back to the question. Right. Question is posterior inferior cerebellar artery, which does not supply the visual pathway. We just seen it. Posterior cerebral artery is a possible answer. And anterior communicating artery, no. Middle cerebral artery, that goes to the Meyer's loop, and anterior cerebral artery does not supply the beyond the optic chiasm. So the answer most likely is posterior cerebral artery. Or it could be or also posterior communicating artery plus anterior choroidal artery. Right. Anyway, let's move on. The answer is B. But however, this is a very, very, I would say, difficult question to remember and answer, but just go with it. Let's go to the next question. Right. This is a 20-year-old patient presents to the emergency department with headache, dizziness, and tachycardia. They are known asthmatic and are on a salbutamol inhaler and a theophylline. They had been seen in the emergency department a few days before and prescribed an antibiotic. Which antibiotic was most likely given, which has caused her symptoms? These are very popular type of questions, which may again come in the real exam, which means you get a scenario of patient coming on certain new onset symptoms after they started on an antibiotic. So it says few days before he was given an antibiotic. So an antibiotic, new symptoms, what's the question stem? So they're probably asking about the enzyme inhibition or enzyme induction. So most likely if it is, so let's see, the drugs will be suspicious drugs that depends on the enzyme P450. We know that theophylline is one of those drugs. And if you remember the enzyme inducer inhibitors, so let's look into the question and the answer stem and see what are the options there. So yes, so these are all antibiotics. However, we know to cause theophylline toxicity, we need P450 inhibitors, and the inhibitors usually are either quinolones or macrolides, right? So in this question stem, there is no macrolides, no azithromycin, clarithromycin, no. And quinolones, yes, we have one quinolone, so ciprofloxacin. Yes, ciprofloxacin is a P450 inhibitor, which can cause a toxicity or a high level of theophylline in the blood that can cause tachycardia, headache, and dizziness, right? This is just a straightforward question, and we should all be able to answer this question. It's a never miss question. So please memorize P450 inducers and inhibitors, especially the antibiotics. Let's move on to the next question. Answer is A, that's right. Right. Next question is, a general practitioner refers a patient with increasing neck stiffness and headache who has been unwell for a few days. An LP is performed in your observation unit. Which of these CSF findings make a diagnosis of a meningitis most likely? So, right, this is a patient with suspected meningitis. You've done an LP. Now they're asking the question of, they're looking at the CSF report with suspected viral meningitis. So let's look into the answers. Right. Elevated opening pressure, more than 60% serum glucose, normal protein, cloudy appearance, WC0 to 5, which is normal. So if we know the most, I would say, specific for viral meningitis is none of these, not protein, cloudy or normal cells, or even opening pressure. The more specific for viral meningitis is elevated serum glucose, which is the B. However, if it is lower than 50%, most likely it could be either bacterial or tuberculous. So increased serum glucose more than 50 or 60% is most likely indicating viral meningitis in the CSF report. So that's another straightforward question. All right, let's go into the next. Right. A 67-year-old man who with a 2-month history of worsening left upper arm and shoulder pain. There is a weakness of shoulder abduction and reduced sensation over the deltoid. Right. You suspect cervical radiculopathy. What level of cervical spine is most likely affected? So, elderly man, left upper arm and shoulder pain, and weakness in shoulder abduction. Well, so weakness in shoulder abduction and reduced sensation on the deltoid. So definitely, and we are suspecting a deltoid muscle weakness for some reason, most likely cervical radiculopathy. So what is the nerve root supplying? The question is, yes, what's nerve root supplying the deltoid muscle and the overlying skin? Well, we will know it's always C5 in the deltoid muscle. So it's another straightforward anatomy question. Nothing fancy about this. Just to recognize that weakness of deltoid muscle and the nerve root supplying the muscle. Next question is, right, there's an image down there, right? A 34-year-old man presents after injuring right shoulder playing hockey, right? You decide to examine each of the relevant shoulder muscles in turn. You position him as shown below. He's unable to maintain this position with his right arm as you push downwards on both arms. This is a very interesting question. The question is, what muscle is most likely to be injured? So if you don't know what examination they're doing and what muscle they're testing, or obviously we can suspect that there was a acute right shoulder injury during hockey game, and you're testing the shoulder muscles, most likely the rotator cuff muscles, which are all these down here. So infraspinatus, subscapularis, supraspinatus, and teres minor. So all these four muscles are combined together, called, creating the rotator cuff. So we can do, there are individual special tests to examine this muscle. Actually, this is not an easy question for FRCEM primary or MRCEM SPA primary, because this is actually a question for the MRCEM OSCE exam. So I would say don't panic if you don't know the answer. But however, if you do want to learn, they expect you to know the special test of the rotator cuff muscles. So this is the test which is called Jobs test or empty can test, which, well, you do put your patient's arms in this position, thumbs downwards, and you press on both arms and see if they can resist your downward pressure. Well, if they can't resist your pressure, then the suspected lesion is the supraspinatus muscle tear. So weakness in this test, which is positive on downward pressure on the arms, might cause these might be positive for supraspinous muscle tear. So we can only be able to answer this if we know exactly what is a Jobs test or empty cans test. Just read through it. And the other tests you might also need to know, special tests in case of infraspinatus we do, and resisted external rotation. For subscapularis we do a test called Gerber's lift-off test. There is no specific test for teres minor, to my knowledge. And this is also not examination test for deltoid muscle sense with supraspinatus, and we need to read a little bit more. And again, this is not an ideal question for MRCEM primary unless you really read the books on or a special test on MRCEM OSCE exams. Let's move on to the next question. Right. A 45-year-old man requires procedural sedation for DC cardioversion of atrial fibrillation. You plan to use Propofol. Sedation is most likely to occur as a result of action on what type of receptor? This is a basic pharmacology question on one of the anesthetic drug, which is Propofol, right? We all know that Propofol is a sedative agent that can be used for either procedural sedation in ED or anesthesia, for general anesthesia. And the answer is, so most of the general anesthetic or sedative drugs acts on GABA receptors, except for, I would say, ketamine, which acts on NMDA receptor. So actually, Propofol is a GABA receptor agonist, is actually increase the duration of opening of the GABA activated chloride channel, which actually cause influx of chloride inside the neuronal cells, causing hyperpolarization and then result in sedation. All right, so that's another straightforward question. We just need to know the pharmacology on sedative or anesthetic drugs. Let's move on to the next. Right. Question number 7, another question with imaging. So what do you see in the images? Right, you can see someone is holding the piece of paper right and the left. So normally they're trying to hold it, probably is resisting the paper. Anyway, let's move on to the question. A 29-year-old woman presents to the emergency department after injuring her left elbow. She is complaining of a weak grip in her left hand. Right. You asked her to hold on to a piece of paper with both hands as you try to pull it away from her. The result of this clinical test is shown below. Right. Left arm. So this is the lady with left elbow injury, and you asked her to hold a piece of paper with both thumb and hand, and you tried to pull it off from her. Right, and the first in the right hand, she's resisting just as normally we do, like pressing the thumb and the rest of the hand together. This one on the left hand, we can say there is a little bit weakness probably between her thumb and the index finger. That's why he's trying to stop it by putting pressure on the distal phalanx of the thumb, pressing it down and resisting it to take it off or pull it away. So anyway, the question, it's a shuttle it was shuttle a question. It's a shuttle thing. You need to notice that the weakness here is actually the interosseous muscles that cause abduction of fingers here in between index and thumb on the left hand. So, abduction fingers normally is done by the interosseous muscles. The question is obviously what nerve is most likely to be damaged. So interosseous muscle is always supplied with the ulnar nerve. The answer, if you know this, the answer is straightforward right there. It's E, ulnar nerve. Right. Next question, again, looks like an antibiotic related question. So a 78-year-old man requires treatment with an antibiotic. He takes warfarin for atrial fibrillation. Same question, like P450 questions. See, even with a sample question, they put two questions with enzyme induction and like inhibitors and inducers. So I can pretty much sure you will get one or two questions on based on this list. So again, someone taking warfarin and you start an antibiotic, you're about to start an antibiotic. What antibiotic is the safest choice in this patient? Obviously, they want us to avoid any enzyme inducers and inhibitors, so the patient can take warfarin safely, right? So in the previous question, we know that inducers antibiotics are quinolones or macrolides. So here is say quinolones, ciprofloxacin. So that's an inducer. We can give that one. And clarithromycin is macrolide. So these are another inducer. So I can give cipro or clarithromycin. And in terms of inhibitors, we know there are another two common groups. One is sulfur drugs, which is cotrimoxazole. So this is an inhibitor. We can't give that. And sorry, these are, so so these two are inhibitor actually. So quinolones and macrolides are inhibitors, and doxy and the sulfur drugs, these two are inducers. So we need to avoid all these four drugs to help the steady level of warfarin on this gentleman with atrial fibrillation. So the ideal antibiotic on this list should be cefalexin. All right. So I think these are all 8 questions in this sample scenario. I would again say these are straightforward, simple questions, but some are really tricky, like asking you the blood supply of the visual pathway, or asking you to understand if you didn't study on MRCEM, if they ask you to know the special name of the special test and on certain muscles, like Jobs test or anti-Cannes test, that is, I would say, a bit of challenge if you're not studying for MRCEM, or if you're not a trainee in emergency department in A&E. And the rest is straightforward. Also, you need to be aware there are a lot of pharmacology questions coming in. So pharmacological questions are very popular in the MRCEM exams, and damage of nerves and test to reveal the nerve injury are also important. So I guess all of you enjoyed the discussion so far. If you have any questions, just let me know. We'll try to do more questions if you like me to go through it sometimes. And till then, thank you so much. We'll see you soon.